A good candidate for penile implant is a patient who wants to get adequate rigid erections for satisfactory intercourse and is not responding to other therapies or does not wish to try other therapies or cannot try other therapies. Of course, the way our guidelines were set up in the past was that we were asking physicians to go through a step care model. You have to try the pill, and if the pill doesn't work, you have to try injections, and if that doesn't work, then and only then you offer surgery. The most recent American Urological Association guidelines has done away with that requirement. It doesn't mean that as soon as a patient walks into the office, they should be offered a penile implant as first-line treatment. That would not be appropriate or ethical. But it is also important for us to understand that there are some patients who may in fact choose that option when they become aware of the other options and decide that for them, this is an option. If that discussion and that shared decision-making has occurred, then I think that patient could be a candidate for penile implant surgery, as well as the other treatments that we talked about. Insurances often cover the procedure. I always advise the patients to check with their own insurance because we know that different policies have different requirements. Read the fine print. The office can also check, but the first and most important step is for the patient to check with their own insurance company. Our experience has been the vast majority of insurances, including Medicare, cover the procedure. But of course, this is never guaranteed and the patients should check as well. The general category of penile implants that are available in the United States are the malleable or semi-rigid implants, as well as inflatable implants. I'm often asked by patients to explain the difference between a malleable and an inflatable implant. In broader terms, the main difference is that the inflatable implant has a pump and a reservoir that allows the patient to achieve an erection and then depress a button that would bring the penis back to a flaccid state. A malleable implant, which can of course be very helpful for patients who have issues using their hands, dexterity issues, strength issues, is always the same length and girth. Arguably, it is less cosmetic because it cannot really be fully flaccid, but it has its use in certain group of patients. The implants are sized individually for each patient. This is probably the most frequently asked question. Doc, what is my penis size going to be? And the answer is, we measure every patient in the operating room and choose a cylinder size that fits your individual characteristics. And this is a very, very precise procedure, and we use every tool available to us to fit in the perfect size for an individual patient. Ejaculation and sensation should be the same after penile prosthesis surgery for the vast majority of patients. I would say, in my case, because I prefer the penoscrotal approach where we are nowhere near the sensory nerves, if a patient is able to ejaculate before implant surgery, let's say a patient who has not had radical prostatectomy and We know that that is a procedure, for example, that removes the seminal vesicles where these patients are not ejaculating to start with. But if you are able to ejaculate, you will be able to ejaculate after implant surgery as well. And the sensation, as I said, should also be unaffected, especially for patients who are having their implant placed through a penoscrotal approach, which is my preferred approach. The patients often want to know if the penile implant is concealed, and the answer is yes, especially when you have a 3-piece inflatable implant that is in a flaccid state, when you're not using it, when it's not pumped up. It is concealed. Nobody knows you have it by looking at you. Of course, if you feel the skin, if you feel the tissues, you know that there is a device inside, but from an appearance standpoint, the device is absolutely concealed. The implants are typically made of either silicone, or in the case of Coloplast inflatable implants, made of the Bioflex polymer, which has excellent tensile strength and provides excellent rigidity. The solution that we put inside the inflatable implants is just salt water. Patients often want to know, in the very, very unlikely chance that there is a device failure, what happens to that solution? And I tell them, look, it's just salt water, the body absorbs it, and it is very, very safe and not something for them to worry about. So to summarize the procedure for implanting the device, I would say it involves a small incision, in my case, preferring the penoscrotal approach. So it involves a small opening in the scrotum at the junction of the penis and the scrotum. We can access the erectile chambers, the corporal body is what we call. This is the erect part of the erectile part of the penis, and put in the cylinders through this small opening in the scrotum. The reservoir will either go in what we call the retropubic space, which is the space right next to the bladder, again through that same opening. You do not need to make a separate incision for that, or in some cases, especially cases where the patient may have had prostatectomy for prostate cancer or a cystectomy, they may be placed under the abdominal muscles, again through the same small opening. And finally, there is a pump, as I said, that is connected to the cylinders, as well as the reservoir that is holding the fluid. And that pump is placed in the scrotum. So again, to summarize, it's a small opening in the scrotum where the cylinders are placed in the penis. The reservoir, which holds the salt water, the saline solution, gets placed either next to the bladder or under the abdominal muscles. And then a very small pump that is what the patient uses to operate the device, that's placed in the scrotum in a totally non-visible and concealed position. Of course, this is surgery in a very sensitive area, and it is expected that the patients will have pain and discomfort for at least a week. I would say this discomfort and not feeling back to normal will continue up to about 4 weeks. The vast majority of our patients are able to use their device 4 to 6 weeks after surgery. For patients who get their implant placed through what we call an infrapubic approach, which is going from above, if you would, often because the scrotum does not have a scar, they can use it earlier. I prefer the scrotal approach for a variety of reasons, and I would say in this scenario, most patients will be able to use it at the 6-week point. Can you use it earlier? Yes, but my preference is to tell the patients to use it at week 6. Of course, I see them after the surgery until that point, but 6 weeks is a fair time period to quote for the patients. One of the things that has improved dramatically over the last 20 years is the durability and the quality of the implants. We know, and this is based on even older data, that 10 years out, more than 80% of these devices are still functional. I would say that if we did a similar study now, that number will probably be closer to 85 to 90% of these devices will be functional. Can you see a failure earlier on? Of course, just like when you get a car, you could end up with one that fails sooner, but in general, they're extremely reliable, and I have seen implants last as long as 20 years even. So what are the satisfaction rates for penile implant surgery? And I think this is an especially important question because it very much depends on the patient and the surgeon and what you discussed with the patient beforehand. Were they aware of the risks and benefits? Did they know that the device that they're getting works the way that it does? I think if you follow those guidelines, if you've had an open discussion with a patient, if you've had shared decision making, the satisfaction rates can be definitely north of 90%. And that has certainly been my experience as well. So I would confidently tell you that if the patient is aware of the advantages and the disadvantages of the treatment that you're offering them and chooses it, the satisfaction rates will be extremely high. So we know all the good things about penile implants, right? The ability to restore man's ability to have rigid erections for satisfactory intercourse. The ability to, I would say, be spontaneous. This is in many ways the most spontaneous treatment we have available. We don't have to worry about interactions with drugs. We don't have to worry about carrying needles and medications and all of that. But of course, with everything good, there are risks, and it's very, very important for our patients to be aware of the risks of penile prosthesis surgery. As with any surgery, the procedure involves general operative risks, right? Chance of bleeding, chance of anesthesia problems, and these are very, very small these days, but there are risks that the patient should be aware of. More specific to penile implants, we worry about infections. This should be 1% or less in a non-diabetic patient and slightly higher in diabetics, and of course higher in those with redo or repeat penile prosthesis surgery for a variety of reasons. Then there are the rare complications, which I'll talk about briefly, but also patients want to know about the chance of malfunction. And I briefly talked about this earlier, and that is that when you do an implant, the reliability is such that after 10 years, more than 80%, I would say nowadays 80 to 85% of these devices are still working. But it is important for the patient to know that there is a potential chance of malfunction. And then, of course, there are the rare complications of erosion, that's the device finding its way to another part of our body, let's say erosion into the bladder or the gastrointestinal system, which are extremely rare, but it's important for the patient to be aware of. There are also patients that no matter what precautions are taken will experience to have pain. In my practice, that has been exceedingly rare, but again, just like with any surgery, the patient should be told that there is a small chance that you will experience pain beyond the typical 4 to 6 week period that we normally advise patients.